speaker is Dr. Albert Cole from the Yale School of Public Health, and his title.
Great. Thank you very much, Fabiano, and thank you very much again also to Adam and for Stephen for the kind invitation to speak. So I'm going to talk about, I'm going to come from the other end of where Jason was heading towards. These are Wolbachia-based interventions for arboviral diseases. Will this be a public health success? And really looking at studies done in those communities that you can see in the upper photos, and the experience in Brazil. Just as a quick disclosure, so I'm a member of Scientific Advisory Committee for a dengue vaccine development program from Merck, have a research grants with Takeda on antibody response for Zika infection, and Valneva, you have a research grant to design chikungunya vaccine trials. So just as a quick overview, I'm going to touch on three things. Again, calling on the work that many people, and particularly Brazilian Ministry of Health World Mosquito Program, have been doing in Brazil, and kind of giving an update on where we stand. First is the, I'll talk about where we're at with the Evita Dengue Cluster Randomized Control Trial, which is being supported both by the Brazilian Ministry of Health and the NIAID. Then I'll go into the observational studies that have been done as Wolbachia-based interventions have been rolled out in this country and will continue to roll out, and give some insights on potential threats that may occur. And then last, I'll talk about, try to come back and touch base on some of the discussion points that came out this morning, but really go back to that rationale for multi-level interventions, calling on the experience that we've had in Brazil. So many of you all know this. This is really the pivotal AWED study, where they've gotten 77% protection against arboviral infections, or particularly all arboviral infections, done in Yogyakarta. This is a population of 453,000. In that study, they released WML-infected eggs. It was a cluster randomized controlled trial. They did 24 clusters. Their design was a test-negative case control study. The primary outcome of interest was disease. And that set the stage for WHO pre-qualification of this intervention by WMP. But really to provide additional evidence and also to support recommendations done by ACAD, we set up a second trial, which was designed in a very different area. This was also required by the Brazilian Ministry of Health. And this is the Evita trial, dengue trial, which is conducted in Belo Horizonte, population 2.3 million, a much more complex urban environmental setting. In this setting, because of the underlying violence, the difficulty in really releasing and getting into people's households and releasing infected eggs, WML-infected adults were released by car, released during car rides or during motorcycles, and sometimes by foot. This trial, we designed it, I'm one of the co-PIs along with Derek Cummings, who's here, as well as Mauro Teixeira and Sri Edupanganti from Emory University. This was designed as a traditional cohort study. We focused on school children, so 7 to 13 years, and chose as the primary outcome infection, or serologically ascertained infection. And this trial was a kind of an amazing feat. It took about 10 years from concept. This was actually the idea of conceived by Mauro Teixeira, who's at the Federal University of Minas Gerais in Belo Horizonte, able to recruit. Many travails happened through this, but through the help of Júlio Croda, who was at that time the director of communicable diseases at the CDC equivalent of organization, Brazilian Ministry of Health. There was some leveraging where the Ministry of Health paid for the intervention, and NIAID invested in the evaluation. With the help with Matt Hitchings at Florida and Derek, we designed 58 clusters, all of them within 500 or 1 kilometer distance from each other, to prevent some of the issues that came up in the AWED study, such as contamination of control clusters with releases done in intervention clusters. This was designed as a school-based study, so where we could go to schools, kind of lighter touch, going to schools. We recruited 3,600 school children in 2020. As I mentioned, the primary endpoint was serologically assigned ascertained intervention. It was, the primary analysis was an intention to treat, but there's also per protocol, when we based on clusters, or using clusters that hit the 60% introgression point threshold, and I'll come back to why that's important. But as you can imagine, this study was started January 1st, 2020, and we were hit with COVID in the pandemic, and immediately this study had to go from a school-based study to doing household visits. And just very quickly on where we're at, so we first suffered the pandemic lockdown and school closures. For that, the baseline survey was delayed, had to be done going to each member's house, heroic work by Mauro Teixeira and his team. The intervention was also delayed because of the lockdown and the effect on the production of infected mosquitoes at the biofactory. And so we had to add an additional year of follow-up, of which we did 4 sequential serosurveys to ascertain serological infections. We hit the jackpot, I guess it depends on how you think about it, in 2024. But that was when, as Julia mentioned earlier in the day, the vaccination program came out exactly at that age group where we had our students. So those participants had to be excluded, those who got vaccinated. So we're right in the middle of performing serological testing. It should be done by October 2025. We should be unblinded by January 2026. So hopefully by the next endgame we can show the report of this, but we do have some preliminary data on the entomological secondary outcomes. And you can see here, this was rolled out in the 58 cluster, the 29 intervention clusters in 3 phases. After establishment phase, we had 74% of the cluster, reached introgression of 74% after establishment phase. At the time we did the per protocol, analysis, which was after all the interventions have been, intervention phases were done, 79 or 80% of the clusters achieved that per protocol target of 60%. And in the final year, this was stable. We had stable introgression, so 70% in the final year, and very little contamination in the control clusters. So we're going to get, hopefully we'll have that information to inform a very different setting from Yogyakarta, a very complex environment, really suffering from many of the social issues of social inequity that Katie talked about early in the morning. And for that reason, it's really good to see how, I just want to go over how these mechanisms, both the social inequity, the urbanization, really may create potential threats that may mitigate the effectiveness of these these Wolbachia-based population replacement interventions. And let me go through this. So Jason talked about that last step about the reduced arboviral transmission and the viral escape, but there are all these other potential threats. One of them is the releases, really going into what these urban informal settlements, these, in Portuguese we'd say favelas, very difficult to access, either because of the being able to get a car through these streets, but also because of the underlying violence which have plagued Brazil. The other issue about what's the threshold? Is that 60% threshold really good enough? Reducing, is a 40% residual wild type population good enough for transmission blocking? And how's the dosing calibrated to underlying abundance? The potential barriers of admixtures, of population structures of wild type of mosquitoes, which may restrict admixturing, curing, and these are all temperature, the next parts are all potentially temperature mediated, whether it's curing of WML or incomplete maternal inheritance or incomplete cytoplasmic incompatibility, or associated fitness costs with WML infections. So really trying to tease down with these upstream factors, as well as the factors that Jason mentioned is really going to be key. So let's go back and let's go to the system where which has been literally pressure tested, and certainly with the 2024 epidemic in Brazil. And we'll go back to the city of Rio de Janeiro, where interventions were done from 2017 to 2019. This was a collaboration with Henrik Salge and Derek Cummings, and of course Luciano Moreira from the World Mosquito Program, 3 exuberant postdocs and PhD students, Gabriel Ribeiro dos Santos, Paloma Carcamo, and Elizabeth Nelson, and really working off of some of the very important study that Gabriel Ribeiro dos Santos and Henrik did with Luciano Moreira, in that where they estimated the effect of the release program in real-world situations during the intervention from 2017 to 2020. And so we extended that study, and you can see in the bottom, this is a region of Rio de Janeiro, about 900,000 people. It's in the northeast, very heterogeneous in terms of its socioeconomic status. Releases were done in primarily large majority between 2017 and the beginning of 2020. So we, in that red rectangle shows that initial study where Henrik and his group looked at, and then we're now looking what happened in the subsequent 4 years, including that 2024 epidemic in Rio de Janeiro. So the first question is how successful was introgression? And we had a situation in Rio de Janeiro very much different from what Julio experienced in Campo Grande when he presented earlier, is that just, very different trajectories that communities experience with their WML introgression. You can see the first problem on the left-hand side is that many communities didn't get the same dose. And you see those blue regions that were underdosed. Those are the poorest areas of the city of Rio de Janeiro, what we call Morro Complexo Animal, that got underdosed. So you get poor people getting underdosed, not getting enough dose. And introgression subsequently was highly heterogeneous. And this was, the WMP did extensive trapping, and you can see this is group-based trajectory modeling of these traps. You could really see 4 different trajectories. One where you release it and you get great introgression, and others, clusters where you get lower and lower, and some, even though despite multiple releases, you can't get good introgression. So Elizabeth Nelson and Paloma Carcamo and Gabriel Ribeiro dos Santos drilled down on this using spatial temporal modeling, specifically INLA, to look at introgression and spatial temporal analysis of these 955 traps between 2017 and 2020. And what they found, and I apologize, this is very small, but I'll just run through. What they found is that the higher the temperature, the poorer the introgression. The higher the monthly temperature, the poorer the introgression. I'm saying weekly temperature, the poorer the introgression. That there were specific built environmental features and low socioeconomic class, which was associated with a poor introgression, and that Aedes aegypti abundance, ascertained by trap counts, were also inversely correlated with introgression. The more, higher abundance, the lower the rates of introgression. However, once everything was set in stone between when the releases were done, primarily 2017 to 2020, you had this stable introgression. There was highly spatially heterogeneous, but it was maintained. You can see in the red is the BG trapping, and the blue is the introgression on the by OV trapping, as ascertained by OV trapping. And during that period, so this is the effectiveness study that done with using INLA models, that there was really a lack of effectiveness of the WML introgression on cumulative dengue risk in that 4-year period after the majority of that introgression was performed. This you can see on the x-axis is the WML introgression at that start of that period, of the follow-up period, and then the subsequent risk of dengue incidence. So there was a negative but non-significant effect. When we broke that down by year, you saw kind of this strange flipping. So if you looked at 2021, 2022, 23, you could see that the higher the introgression you had back in 2019 and 2020, the lower you had lower you had a reduction in incidence in 2020-23, but that flipped in 2024. And that really suggested, this was work done with Paloma, is that there could be potential temporal spatial confounding. That was it. So Paloma took the same, introgression areas based on, same areas coded by their introgression in 2019-20 and looked back. And you can see this flipping effect even way before the intervention happened, indicating that the spatial distribution of dengue risk was time varying prior to the intervention. So we're scratching our heads. Derek and myself are co-leading this project. And so one certainly is uncontrolled confounding for temporally varying spatial risk structures. And these could be changes, in Aedes aegypti abundance. It could be changes in population susceptibility. It also could be our gut feeling is that it's really this potentially the immune dynamics and the temporal spatial changes in population susceptibility, which may reflect past incidents and modify the relative effect of future Wolbachia-based interventions. There are other explanations, such as, and one of the key things that we worry about, and I think some of you may have heard the studies from the tiers, but are we really, when we get 60% introgression or 70% introgression, are we leaving nothing behind? Or is there residual wild type Aedes aegypti that could drive transmission, particularly during a large outbreak? As Jason has said, there's always the concern for leaky WML-mediated blocking, particularly at high environmental temperatures like we experienced in Brazil last year, and then new dengue serotypes that are less susceptible to WML blocking. I'm not going to go over that, but I just want to write the caveat that that's Rio de Janeiro. We are concerned that something like that may occur in a heterogeneous, complex urban environment such as Belo Horizonte, but that wasn't the case, and you saw the data earlier from Campo Grande. There was also other places, 2 other cities where WPMP have released WML-infected Aedes aegypti. This is Campo Grande, which Julia showed, but you can see there was pretty good heterogeneous high-level introgression, and there was effect. There's a transmission blocking, there was a reduction in dengue cases, a significant reduction in dengue cases during the 2024 epidemic. So the jury's not out, and I think one of the key questions that place matters, where you live matters, why does this intervention work differently in different places? And so going back to the scheme, at least from the example of Rio de Janeiro, so certainly under-releasing, due to access and operational constraints is a key issue. And that's really key because we don't want a situation like rotavirus where this is effective for the rich and ineffective for the poor, and we increase social inequity. The second is this issue of the suboptimal dosing, not calibrated to Aedes aegypti abundance. And what is that threshold? What's that point that we need to get in terms of either reduction of wild type or overall proportions of introgression in order to have effect, a transmission blocking effect? And then the other, and I want to call to attention, this is work done by people at Fiocruz, Rafael Maciel de Freitas, just came out in PLS neglected disease that, there's certainly what we long suspected in the what we know in the laboratory, but, we suspect in the field that there are WML-associated fitness costs, and particularly in the eggs, in the survival of the eggs. And when you combine that with pesticides, and Jason, I'm not sure if this is what you were referring to, this study you were referring to, but when you crash the population with pesticides and vector control, is it the wild types that come back in the WML that because of this fitness cost that don't? But I think I want to just end with this last point about really what's going to affect or modify the effectiveness of the WML interventions is really this issue of the underlying population susceptibility. And this really gets to, and I'll close up with this last slide, and this is a completely incorrect, oversimplified model, but it's just to get out the concepts. And some of them that were touched about yesterday, this issue between the interaction between force of infection and susceptibility. When the higher the force of infection, the lower susceptibility of the population, and converse. And when you have vector control, you reduce that force of infection, but you increase the susceptibility in the population. Henrik mentioned the issue of rubella, but I think many of you may not be old enough, but remember just the terrible situations that happened in Sri Lanka with malaria, where it came back, after it was almost eliminated, it came back with a vengeance, with severe forms among adult, severe manifestations and outcomes among adult populations. So this is the issue, the rationale for the vaccination, where when we have this increased susceptibility, we reduce that by vaccination, reduce susceptibility, lower that curve. Again, this is an oversimplified model. And I think what's going to be key, and I think this was part of the discussion earlier today with Katie and Henrik, is that what are the set points? We know that the threats are going to be waning immunity. So how much waning immunity do we need to keep a population safe? And then how much release from vector control can we tolerate, and really getting that. So I'm just going to, this is a summary slide, so really understanding a critical need, and I think that's where the models that had replaced is really that understanding that interaction of the population susceptibility and vector control. We certainly need a new generation of researchers. I was driving in a car with Adam Weichman in Singapore after visiting Engong in last June, and we saw this Dengue Warrior 2.0. So hopefully the young people here are going to be those the second iteration of Dengue Warriors. We need who can help us understand what are those thresholds to guide boosters and redeployment of vector control. And this gets back to the point about, what's the type of vaccine we need? And really, the key issue is going to be the disease blocking rather than transmission blocking, so we can offset that risk of increased population susceptibility and preserve that natural boosting. And then the last point I want to touch about is that, we're going to have these multi-level interventions in this dynamic model. Henrik raised that, but this is just, in the cyan is 2024, and then the blue is 2020, and you can just see that shift in hospitalizations and deaths to the elderly, and those are the people that we're going to have to be taking increasingly more of. So just acknowledgements, the Avita team, Derek Cummings, partner in crime on this, along with Mauro Teixeira, Sri Edpunganti from Emory University, Giulio Croda and his group, who's done a lot of the test-negative case control studies, and will be doing more on the Wolbachia, our laboratory at Yale, and also our team here, several of them who are here from the Fiocruz, the Oswaldo Cruz Foundation in Salvador. So thank you very much. Sorry that I've gone over. I think I told you 2 minutes. It's 3 minutes.